other rare diagnosis as vasa previa or any other local pathologies. So this is one of the major cause of KPH. So if we see the causes of KPH, placenta previa is most common than this, which has incidence of 4 to 5 in 1,000 cases of all pregnancies. Placental abruption incidence in 1% of all pregnancies. So other causes of KPH are like indeterminate origin. So it can be vasa previa. What is vasa previa? Vasa previa is when the placental vessels or fetal vessels come in front of the cervical os, or there is sharing of fetal vessels, placental vessels which are giving, which are there to supply the fetus. So if there is any injury to those vessels, that is vasa previa, any kind of vessel which is coming in front of the cervix or during delivery. Then pathology of cervix, it can be cervical erosion, any kind of polyp, tumors of cervix, and bleeding from the lower genital tract because of any kind of trauma. And cause blood stained cervical mucus, which is also known as SHO. So these are the main causes of antepartum hemorrhage. Now placental abruption. Are you able to see my screen? Because there's some this webinar icon is coming in front of my screen. Are you people able to see the full screen? So what is placental abruption? It is the premature separation of normally situated placenta from the uterine wall. What happens in the placenta previa? There is low-lying placenta. Placenta is coming till os or within the lower margin of the lower uterine segment, or covering os or till reaching the os. So there is abnormal placement of placenta in the placenta previa, but abruption in this, there is a normal situated placenta, and because of that, so what happens in abruption? There is some hemorrhage at the bed of the placenta, which extend and which shear off all the placenta from the uterine wall, and it bleeds. So there is a formation of hematoma, and that hematoma increase inside further because of that pressure of hematoma, which leads to separation of the adjacent placenta. So initially that hematoma is small, and because of the pressure, it increases and causes the abruption or separation of the placenta from its site. So basically, there are, when we see the where the presenting complaints of the fetal of the mother is seen, it can be a concealed or a revealed abruption. Concealed is when, as you can see in this picture, there is a abruption or hematoma formation behind the placenta, which is increasing, but it is not revealed. It remains behind the placenta, but it causes separation of placenta and hamper the blood supply to the fetus, but it is not coming through the os. So this is concealed hemorrhage. So in this case, hematoma is not reaching to the margin of placenta or the cervix. So whatever blood loss is there, you cannot get the correct estimation of that blood loss, because the clinical findings are because of the blood loss. She can be in hypovolemia or shock, but you can't see those that kind of bleeding from the vagina. So the correlation between the amount of the hemorrhage in this situation is very difficult. Now the revealed one is when the placenta, there is a space, and the bleed comes out of the uterus and cervix. So you can see the bleeding coming from the cervix, but it also may not corroborate with the actual loss, because here the hematoma is there, which you cannot see, but you only seeing the bleeding or spotting which is coming out of the cervix. But the risk factors of placenta is the if two abruptions, there is a history of abruption, two previous abruption, there is a recurrence chances of 19 to 25. In one abruption, the overall chances, the range is 9 to 17%. And if one abruption has occurred, and two is 19 to 25%. Then the preeclampsias or thrombophilias, in which there is a high BP, their fragile vessels are there, abnormal placentation, abnormal vasculature is there. So because of that, preeclampsia and thrombophilia. Thrombophilia means what is thrombophilia? What the other the diagnosis which comes in thrombophilia? Those are a antiphospholipid antibody syndrome. So this comes in thrombophilia. Then fetal growth restriction. How fetal growth restriction is a risk factor? Because many times there is abruption because of high BP or abnormal presentation, which is not revealed, which you cannot, that is missed, which there is no history, nothing in early pregnancy, like patients come with hematoma, retroplacental hematoma or spotting, which is there, but it resolves with time. So what happens in that cases, that separation, because of that separation, that injury has occurred, there is the supply is decreased to the fetus, and because of that there is fetal growth restriction. We don't get any signs or any separation, placental separation on imaging or nothing. So fetal restriction can be one of the it it can be a due to the placental separation, and it can lead, because the whatever the pathology is there, that is there. So because of that, it can be associated with placental abruption. Non-vertex presentation is there because of malpresentation. Polyhydramnios, because sudden decompression of the uterine wall or the placenta, because whenever there is a leak. So that polyhydramnios is one of the cause. Advanced maternal age, basically after 40 years of age. Multiparity, multiple pregnancies because of the over-distended uterus and big placenta. Lower body mass index. Pregnancy following the assisted reproductive techniques. Then intrauterine infections, premature rupture of membrane or chorioamnionitis. Because of the infection, there is chances of abruption. Then any kind of abdominal trauma, both accidental or any domestic violence, which leads to the uterine trauma and placenta separation. Then smoking and drug misuse, whether drugs are cocaine, amphetamines, intrauterine hematomas on ultrasound scan in the first trimester. So this is also a risk factor for placental abruption in later on in pregnancy later on, like in third trimester. So these are the risk factors of placental abruption. Now we are coming to the grades. How we grade the placental abruption whenever patient is coming to you. So these grading system, the classification is known as Sheehan Statland's classification of so that divides into 3 grades: mild, moderate, and severe. So mild is when there is that this is not recognized clinically before delivery and usually diagnosed by the presence of retroplacental clot. So how you diagnose the retroplacental clot in this situation when you don't have any kind of complaints or any signs or no imaging done or no features on imaging. So whenever the patient delivers, you suddenly one can find the hematoma behind the placenta. So this is mild, and it is diagnosed only after the placenta is separated of the expulsion of placenta. So basically, this is a retrospective diagnosis. Moderate is when this is the intermediate grade in which the classical signs of abruption are present, but the fetus is still alive. The frequency of fetal heart abnormalities are high because fetal is still alive, but NST can be non-reactive in this. Then severe grade is when in which the fetus is dead, and coagulopathy may be present, may not be present, and blood loss is appreciable in this condition. There is a massive hemorrhage. There is in this situation the fetus is dead because whenever the placental separation is more than 50%, there is always a chances of fetal compromise in these situations. So any placenta where the placenta has gone to beyond 50%, 60%, there can be chances of IUD and massive hemorrhage. So in these cases, the severe one, the severity is because of the IUD. There is chances of IUD. There are chances of coagulopathy because of the massive hemorrhage or TIC. So what we get in the history of a patient when it comes to you with a placental abruption, she can complain of pain abdomen, which is acute and severe in onset, along with vaginal bleeding, which may vary from mild to severe. She can complain loss of fetal movement from the time of pain or bleeding, and in like massive hemorrhages or the severe kind of placental abruption, she may present with shock or hypovolemia. So there can be history of high BP because of the risk factors, leaking PV, fever because of infections, trauma, and thrombophilias. History of early pregnancy bleeding may be present in those cases. So this is a this is a triad of symptoms like pain, abdomen, vaginal bleeding, and maybe in shock, hypovolemia. On examination, we have to assess the first of all in these cases when patient is coming to you with bleeding PV and you find a tense abdomen uh, or trickling of blood over the legs, or there is soaking of bed sheet or underclothing or clothing. So that is that's you have to assess by seeing the patient that what amount of bleeding she has. So according to the general condition and assessment of blood loss, you go with the case. So if she is having the bleeding, you have to immediately check the vitals of the patient, that is pulse, blood pressure, respiratory rate, and saturation. Then directly come to the abdominal palpation in those cases where there is hemorrhage is there, active bleeding is there, because then you don't have to see the other general examination. You have to come to the abdominal examination. On abdominal examination, the abdomen will be tense, tender, and they may not appreciate any kind of uterine contraction because it is persistently tense, or it is called woody feel. So uterine contractions may be there, or persistently contracted uterus will most commonly it is the tense uterus. Fundal height of the uterus may be more than the period of gestation because of the hematoma formation or the abruption, which is or because of the blood which has collected inside the uterine cavity. Then you can, because these sometimes the patient have come to you with bleeding PV, you find all those features of abruption, still you remains in a dilemma of should we go for a speculum examination or digital examination in those cases, because she may have placenta previa or any kind of local pathology. But because if you do a PV examination in a patient of placenta previa, that it may further cause to the increase the bleeding, or there are chances of torrential bleeding. So that should be avoided if diagnosis is the location of placenta is not known. That should be avoided. So because instead of that, you can do a per speculum examination just to see what is the pathology, if you can see some kind of placenta or what kind of active bleeding. So gentle speculum examination can be done, and it also rule out the local pathologies there. So digital examination is done only when you have an ultrasound with you, which is showing a normal situated placenta. Otherwise, you should go for a ultrasound. If there is no previous ultrasound, no information about the placenta, then you should not go for the PV examination. Other indications of pervaginal examination in these cases is to assess the cervical dilatation, or to after ruling out placenta previa. So you want to know in what stage of labor the patient is, what is the cervical dilatation, and all parameters. So and of course to rule out any kind of cord or any kind of pulsations you can feel through the cervix in cases of vasa previa. So one thing here which is you have to remember is that you should not go for PV examination if placenta is the location of placenta is not known. First you have to rule out the placenta previa, then you have to go for digital examination, but speculum examination, gentle speculum examination can be done. So this is the symptoms of revealed and mixed. Concealed mixed means as I told you, there can be hematoma formation, but the exact hemorrhage which has occurred is do not corroborate with the sign. So revealed is when the bleeding is there, mixed or concealed, there's spotting, and still the spotting is there and abruption is there. So, but it is not the bleeding is not of that amount which the abruption has occurred. So you try and feel in both of the cases revealed, because there is no hematoma, nothing is there, the pressure is decreased because all the blood have come out of the cervix. So in those cases you may not find the tender abdomen, or you may appreciate the contractions. But while in concealed, there is tense, tender, and rigid abdomen. Uterine height here is proportionate because of the blood has come out of the cavity. Here it is disproportionately enlarged. So you can appreciate the fetal parts over here in the revealed, and it's difficult to make out in the concealed. FHS is usually present, and basically FHS depends on the type of the severity of hemorrhage. So it may or may not present in both the cases. So what internal investigations you will advise is complete blood count, blood grouping, which is very important because she may need blood transfusion. In any ways, blood grouping is very important in pregnancy, has to be done. Liver function test, kidney function test, coagulation profile. In cases of where there is suspected abruption, USG is less reliable in diagnosis. So it can be done just to know what is the placental location, or to confirm the if you are not able to find any fetal heart with stethoscope or with Doppler, you can confirm that finding on the ultrasound. So if the immediate, suppose patient is bleeding and there can be some delay in collecting all the reports, so you can do bedside BTCT and CRT, that is bleeding time, clotting time, and clot extraction time. That can be done in the done bedside. So USG, as told you, it's less reliable in diagnosis. Why it is less reliable? Because the hematoma which is there, so the imaging that the hematoma and the placenta, you may not differentiate between hematoma and placenta, so that's why it's very difficult to differentiate between them. So that's why the USG is less reliable in diagnosis. So if you see the overall sensitivity, specificity of the ultrasound and the abruption is, the sensitivity is 24% only, specificity 96%, PPV 88, positive predictive value is 88%, and negative predictive value is 53%. Now, what fetal investigation you should do in cases of abruption? Because there's chances of IIT, immediately you should put on the patient on CTG for fetal monitoring. After you stabilize the patient or resuscitate the patient, you should put on the CTG to see the cardiac activity or the NST of the fetus. So whenever possible, ultrasound should be carried out to establish the fetal heart pulsation if fetus is viable. Cannot be detected by, so whenever you are not able to appreciate the fetal heart with the stethoscope and Doppler, you always go for the ultrasound to confirm the diagnosis of intrauterine death. Now comes the management. How should you manage the patient? So first of all is very important is consent taking and counseling of the patient and the relatives. Then you should confirm the availability of blood products in your blood bank for arrangement of blood products. There should be multidisciplinary approach. Gynecologist, anesthesia people, and blood bank in charge all should be involved in this case. There can be different according to the presentation. The management can vary. Like the timing of delivery depends on the maternal status, period of gestation, and fetal, how much the fetal compromise is there. So it can be expectant management, immediate cesarean section, or rupture of membrane and proceed for vaginal delivery. So we have to see in worst cases we can do expectant management, immediate cesarean section, done what kind of conditions, and where we can wait for the vaginal delivery. So in cases of hemorrhage, the first priority of your should be to stabilize the patient. So first of all, ABC, as you always follow in a critical patient, airway should be seen, 10 to 15 liters of oxygen via face masks to be given to the patient. Then after to see the circulation, you should uh, put 214 gauge intravenous line immediately, and you take out all the samples for investigations, and you should connect with the IV fluids, crystalloids or colloids. So basically we start with the crystalloids. So if the BP is not improving with the crystalloid, then we go for the colloid solutions. So if in a kind of shock or hemorrhage, severe hemorrhage, 1 liter of the fluid should go within 1 hour. So to resuscitate or to correct the hypovolemia, and then you can give it 125 ml per hour. Then other monitoring which is required, you should keep that patient on monitors which for continuous PP, monitoring pulse, oxygen saturation, and respiratory rate and urine output. Catheterize the patient immediately to see the urine output. So in cases when you suspect of massive hemorrhage, so in massive hemorrhage, the BP, the patient will be hypovolemia, tachycardia, maybe 120 to 140 of pulse, low BP of 90 or less than 90, and active bleeding is there. So this is indication of massive hemorrhage. Whenever there is tachycardia, that means there is around 30 to 40% of blood loss has been there of total blood volume. So immediately you have to do all the measures as I told you in the previous slides. Then the management should include all the consultant, obstetrician, anesthetists, and blood bank people. Then all the staff should be alerted for the patient. Then, as already told you, the IV fluid should be started, and 2 IV lines should be given in both the hands. So immediately you start the IV fluids. Then you take the sample for blood grouping and other investigations, and that blood grouping should be done and the screening should be done before transfusion. If patient is stable and you have time, it should be followed. The proper protocol should be followed. So in those cases, packed cell is preferred to avoid the overloading. The whole blood, the indication of giving whole blood is when the PCV is not available or in the life-saving conditions. So the ratio we follow is 1 PCV. If we are given 1 PCV, 1 FFP should be transfused. So it is 1-to-1 ratio. So suppose you have arranged 4 PCV, you have to arrange 4 FFPs along with that. In massive hemorrhage, you have to arrange the cryoprecipitates and other blood products like platelets also. I will tell you later how to give those products. And in extreme situation when the blood grouping is unknown, for life-saving purpose, blood group O Rh negative red cells should be given, although they may be incompatible for the patient with irregular antibodies. But for the life-saving purpose, if there is no cross-matched or you don't know the blood group of the patient and there is an immediate need to resuscitate her if she needs blood immediately, so you can give blood O negative blood to the patient. So platelet transfusion is to keep the count above 75 lakhs to control the ongoing bleeding. So there is a specific indication of platelet transfusion because with blood loss there can be thrombocytopenia. So if you do not correct that, there can be ongoing bleeding. So you have to control that bleeding. So that in these cases, the platelet count should be kept above 75 lakhs to control the bleeding. So in those cases, there is a chances of development of disseminated intravascular coagulation. So in these cases where DIC is suspected, the same things you have to give 4 units of FP, 10 units of cryoprecipitate will be given along with the PC. Now mode of delivery. So if the fetal that is diagnosed on the ultrasound, if there is IOD, then vaginal birth is recommended mode of delivery. In those cases where the maternal condition is satisfactory or fetal condition is not compromised, in those cases you can wait for vaginal birth of the fetus. Cesarean sections, there's some situation where you have to do cesarean section in cases of IUD itself is when the fetus is in transverse lie or when you need to expedite the delivery in cases of active bleeding to stabilize the mother, because the time you take in vaginal delivery that will lead to the further increase in blood loss and deterioration. So even if there is IUD, there's some incidences for which you have to do a cesarean section to stop the bleeding. So these are the two indications where you go for cesarean section and vaginal delivery when there is IUD and you have time, the mother is stabilized, there is no much active bleeding, you can wait for vaginal bleeding. So if you opt for vaginal bleeding in those cases, then the fetus should be put on the continuous NST because there are high chances of non-reactive NST because there is abruption, blood loss is there. So that patient should be put on NST and should be kept arranged for OT. The blood product should be with you, the consent and everything, so that you can immediately transfer OT whenever there is a non-reactive fetal heart. Now, what happens in the preterm pregnancies? So, no doubt, when there is term pregnancy, you can immediately terminate the pregnancy. But when the patient is preterm and maternal conditions allows you, then you can wait for a steroid cover for lung maturation. In these cases, usually tuberculosis should be avoided because the drugs which give for tuberculosis may have hamper with vitals. They can cause tachycardia or they can mislead you. That's why the tuberculosis should be avoided. But in some instances where you need for corticosteroid cover, you can give it. Expectant management is given to the mild and the mild cases, and there is no active bleeding, and there is reactive anesthesia. In chronic abruption cases, expected management can be done, where the abruption was unnoticed, and now the mother and fetus is mother is stable, fetus is moving. You can do the expected management. So, in moderate to severe abruptions, regardless of the gestational age, the mother's life should be taken on priority. She should be resuscitated and stabilized before any decision regarding the delivery of the baby. So steroids should be given. Senior pediatrician neonatologist should be involved in the counseling of the woman when extreme preterm birth is likely. Conservative management is usually appropriate when the APH occurs in the extremely preterm pregnancy and mother's condition is stable. So there's if mother is more stable, we should go for the delivery of the fetus. Now what if you are taking patient for LSCS, then regional anesthesia is for operation is always preferred unless there is any kind of contraindications. So can you tell me what can be your contraindications in these cases of abruption? Where we need to go for GA when there is abnormal coagulation profile, low platelets, and patient is in hypovolemia or shock, then we prefer the general anesthesia, otherwise regional anesthesia is preferred. So managing the third stage, you should be the patient should be given prophylactic oxytocin ergometrin to manage the third stage with APH in absence of hypertension. If she's hypertensive, you can give oxytocin only, and if she's not hypertensive, you can give ergometry along with that. So what happens in these cases? The APH arising from the placenta associated with increased risk of PPH. So it's not that if patient is coming with mild or moderate and our HB is like 9 or 10. So you have to arrange those blood products for FFPs, for PCVs, because there can be chances of PPH during the delivery or during the cesarean. So always arrange those blood products for these patients. Platelet should be transfused when there is thrombocytopenia, and the PPH management, as we should go for PPH management as per recommendations. And after the delivery, the placenta should be examined. In cases of Rh negative pregnancy, suppose patient has spotting or mild hemorrhage, then should be given the NTD to prevent the elimination in mother. And after delivery, NTD as a usual doses should be given. Even if the patient of early pregnancy, when they come with spotting, the NTD should be given. Then the complications are, the most common complication after this eruption is hypovolemic shock or hemorrhagic shock. So this is how you, the classification of shock is there, class 1, class 2, class 3, class 4. It is how it is divided. So a blood loss percentage, according to that, the class 1 is less than 15%, 15 to 30%, class 2 31 to 40+% is class 3, and more than 40% is class 4. So in the, as you can see in the table, this tachycardia is starting from when there is 15 to 30% of blood loss. There is 100 to 120 pulse, then this pulse becomes 120 to 140 when there is 30 to 40%, and more than 40 means there is more than 40% of blood volume has gone. Now, similarly, in class 3, the blood pressure start decreasing. Mental status, the patient becomes anxious, confused in class 3, and the fluid requirement, we know class 1 and class 2, when there is no tachycardia or 120, you can give crystalloid, but before after that 120 pulse or the decrease BP, you have to start with blood products or colloids. So because there is a hemodilution and in the pregnancy, though the better index to assess is the shock index, which is calculated by heart rate divided by the systolic blood pressures. The normal range of this shock index is 0.5 to 7. So if this shock index is more than 0.9, that means there is increased morbidity and mortality, and you have to start your process of resuscitation. You should take it as a class 2 or 3. Then you should start with IV fluids and blood products. So shock index is a better it's implemented in pregnancy because of those hemodynamic changes which occurs in pregnancy. Now the next complication is DIC. It's more commonly seen in the concealed abruption because of the high pressure. There is ongoing blood loss, and there is a tissue thromboplastin which is released because of that. So that leads to the DIC, and which further cause the troublesome surgical bleeding because of the impaired coagulation. Then Couvelaire uterus, you can see in the picture the uterus. You can see over here there is a bluish discoloration of the uterus or serosa. So what happens in Couvelaire uterus is during cesarean section, you can find this extravasation of the blood in the musculature and the serosa of uterus. It is also known as uteroplacental apoplexy. So the main concern with this situation is because there is stagnation, there is a formation of hematoma between the layers of the between the musculature of the uterus and the serosa. So what happens, it hampers with the contractility of uterus. So the uterus becomes less less contractible and less respondent to the oxytocics or your uterotonics. Why that happens? Why it becomes less respondent to those oxytocin? Can anybody tell what happens in this condition? Why are there chances of PPH? Because what happens, the uterus in the musculature is in a crisscross fashion, or whenever there is presence of hematoma, it hampers with the contractility of those muscle fibers. So it leads to the PPH. Then next complication is AKI, acute renal or kidney injuries. It happens because of the hypovolemia, which is not treated in time or treated partially. So it is most commonly seen in massive hemorrhage. So what it needs is timely intervention with crystalloid colloids. And these AKI which occurs because of massive hemorrhage, they are usually reversible. So, and rarely they needs dialysis. The urea creat will be increased, but with the if you start your management immediately when you diagnose the AKI, then the condition may be reversible and the patient come out of it. Then Sheehan syndrome, in it also happens in the massive hemorrhage. So what happens in, because of the hypovolemia, there is a pituitary necrosis and pituitary failure. So it will present after delivery. So you won't see any features just after delivery, but when you discharge the patient, she comes with the presentations of lactation failure, amenorrhea, or breast atrophy, hypothyroidism, loss of axillary and pubic hairs. So this is not like every features she will present with every features of lactation failure, amenorrhea. That depends on the amount of necrosis, because there can be varying degree of pituitary necrosis. So this she can present one or two findings like lactation or amenorrhea, breast protein may not be there, hypothyroidism may not be there, or she can present with hypothyroidism or loss of axillary hairs, right? So these are the cases of Sheehan syndrome. So um, it these patients, they can present within like 1 month, or they can take time of years also. So any kind of questions you want to ask? Any questions? So I'm concluding this class. If you want to ask any kind of question, you can put on your message box.